Sharif. I'm an assistant professor in the Department of Medicine and the Division of Critical Care and Emergency Medicine. So I practice both in the ER and the ICU here at McMaster. And the project that I'm going to present on behalf of our authorship group is titled Early versus Delayed Coronary Angiography After Out-of-Hospital Cardiac Arrest in the Absence of ST Elevation. It's a systematic review and meta-analysis of randomized controlled trials. I apologize for the barking dog in the background, but just to give you a slight introduction, I'm so sorry, the dog. Usually when people suffer a cardiac arrest or their heart stops, a number of things are going on. Common things being common, the blood supply to the heart is compromised. Just to give you guys a bit of a background there. For instance, if your hand has a blood supply from the radial artery and the ulnar artery, the same way the heart has its own blood supply from the coronary arteries. Now you can see from the image on the right of the screen where there's a yellow plaque. So as we get older, if our cholesterol levels are higher, or if you have a familial hereditary cholesterol disease of some kind, you end up developing some plaque, and then that obstructs the blood flow to the heart. Now, if that plaque becomes bigger or you have a rupture of the plaque, you have a sudden stopping of blood supply into the heart, and that can cause the heart to stop. And then these people would present as though they've died, and you have to do CPR on them. And we have really good evidence that if they are able to be revived and they have findings of this on their EKG, then they can have an angiogram done by our cardiology colleagues, and they can find the blockage by going in through the artery and then deploy a stent. Once you restore the blood supply, people usually do quite well and they have really good outcomes. So that part's not up for debate. That's actually not what we're studying, but I wanted to provide you the context. So that is called a ST elevation myocardial infarction. A STEMI is the short form. Then there is another branch of cardiac arrests where people will die, but they don't have this finding on EKG. So I'm going to show you that on the next slide. So that's called a non-ST elevation MI. So you don't need to be a cardiologist to read this. I've just highlighted the red circles where the ST segments are higher. And so when the patient comes in the emergency department and their heart stops, we do CPR, we try to revive them. And then once their heart starts beating again, we'll do an EKG. And if it looks like something like this, it's a pretty clear-cut decision. They get some blood thinners, they go to the cath lab, the cardiologist will take a look at their heart and deploy a stent if they need to. And they usually have, like I had mentioned earlier, reasonably good outcomes. Where there's equipoise is if you don't have this, what do you do? Should you do an angiogram right away? Should you do it later? Should you do one at all? And so really what's been happening over the last few decades is people have kind of just been going with experience, or you know what, this kind of seems like they would need an intervention earlier on. I don't think really need it without any good, robust evidence. So in the last probably 5 to 7 years, there have been a number of randomized controlled trials that have come out, including the ARREST trial. It's a trial from the Tomahawk trial in the New England Journal of Medicine. And there's a newer trial of which the results have come out, but the paper hasn't been published yet, called the EMERGE trial. There's also a DISCO trial that's ongoing. So lots of new evidence coming out. And what they're comparing is if you are one of those patients who had their heart stop and you don't have that ST segment elevation, compared to was it better to do things early on, so they're randomized to having early angiography versus being randomized to a delayed angiography or not having it being done at all? And then they've been comparing outcomes like mortality and a bunch of adverse events. So with all of this literature coming out and there being equipoise clinically as to what do we do with these patients in the critical care setting, we figured it was a good time to study this specific population. So our Pico question is, in adult patients with out-of-hospital cardiac arrest without that ST segment elevation, does early angiography compared to delayed or no angiography have an important effect on patients' morbidity and mortality? I'm going to elaborate further on what this means just for the purposes of the slide. I've trimmed the outcome down, but we have a number of outcomes. So why don't we get into the methods part of our literature, of our systematic review? So first things first, we did a search strategy with an expert librarian, and that search strategy is also peer reviewed. And we searched from inception up until November the 12th, 2021. And that included the new literature coming out as well. We searched Medline, Embase, Concurrent, clinical trials registries, and then we went through the searches independently. They were reviewed and in duplicate. We did a risk of bias assessment using the Cochrane Risk of Bias 2.0 tool, looking at randomization, concealment, blinding, outcome data completeness, selective outcomes, and other risks of bias. And as per the Cochrane Risk of Bias tool, if any domain had the lowest rating for risk of bias was applied to the study as a whole, as per the tool. We did our statistical analysis using random effects. We used the Dersimonian and layered model. We used relative risks as well and mean differenes, and the chi-square test were appropriate. And then finally, we used the GRADE approach and used the GRADE Pro website to assess the certainty of evidence in our outcomes, looking at risk of bias and consistency, indirectness and precision, and publication bias as is employed by the GRADE approach. So what did we find with our results? So starting off, we only found 383 papers that fit our search criteria, given that this study wasn't particularly, this topic wasn't particularly well studied. We weren't too surprised by that number. After duplicates being removed, we were at 286. And after removing all the non-relevant articles, we assessed 52 articles in their full text version, and we excluded 47 of them for a variety of reasons, the most common being that it was the wrong design, and many of them were just trial registrations. And we ended up with 5 trials overall. And of the 5 trials overall, the total patient sample was 1,524 patients. So, I mean, certainly not a crazy large number. It'd be great if it was like 10,000 patients, but it's not so small so as to not allow us to make some sort of a conclusion. So that's what we're dealing with here. And then we were able to, after we systematically reviewed all the literature, we were able to pool our findings. So what did we find? So first things first, for mortality, which is the outcome that most people are interested in, we found a relative risk of 1.04 with a confidence interval overlapping 1. So an effect estimate from 0.93 to 1.17 using the GRADE approach, and best practices. We also reported the absolute effect. So a 1.8% reduction in mortality, but in a best case scenario, 3.1% reduction, and in a worst case scenario, a 7.6% increase in mortality. So really, based on this, our GRADE certainty of evidence was also low because we're certainly limited by imprecision here, quite significantly so. So a low certainty of evidence to say that there's probably no effect on mortality based on our findings. Then we looked at, yes, it's important to be alive, but what's more important than being alive after your heart stopped is being alive with a good neurological outcome. So a number of studies reported that as well. And we found, similarly to our mortality outcome, our effect estimate was 0.96 with a confidence interval that, once again, overlapped 1 from 0.85 to 1.08. So an absolute effect of a 1.9% reduction, anywhere from a 7% reduction to a 3.7% increase. This, we were limited here, as you can see, by imprecision as well. Our certainty of our evidence here was also low. So again, based on this limited data set, we can say that there's early angiography may have no effect on survival with good neurological outcome at the point of longest follow-up. Moving on, a couple more outcomes I wanted to highlight is ICU length of stay, because when you're looking at resource use and a patient important outcome, patients like to know in general of how much time they're going to spend on a ventilator, how much time they're going to spend in an ICU. And once again, the trend holds true. If you look at our mean difference of minus 0.41 with the confidence interval overlapping 0, again, not really much of a difference between early angiography or delayed angiography. And finally, we looked at hospitalization. And of course, we're severely limited by imprecision. There was only one study, and it shows, sure, possibly you could leave the hospital 1 day earlier. But again, the certainty in this evidence is quite low. We don't really have enough data there. Because of limitations due to time, I could not show you our subgroup analyses, but we had pre-specified subgroup analyses on our pre-registered protocol where we looked at risk of bias. So we compared high risk of bias studies to low risk of bias studies to find an effect estimate to see if there was a confounder with respect to our results. And we weren't able to find any subgroup effects that would have potentially misled our outcome here. So moving on to the limitation side, one of the big things with these studies is that they defined early angiography and delayed angiography rather differently. So to give you an example, in some studies, they defined early angiography as soon as you got randomized, you got your angiogram, as opposed to within 1 hour of randomization or within 2 hours of randomization. So, I mean, it doesn't sound like it's really different, but, it really depends on when you got randomized, right? So this could, there's definitely some heterogeneity there. And then with respect to delayed angiography, the definitions were all over the place, right? So granted, there's only 5 studies. Some of them had delayed angiography defined as within 6 hours, compared to some of the patients had it done after 4 days. So definitely heterogeneity there as well, which limits our ability to fully interpret our results in a conclusive fashion. From a methodological perspective, as you've seen from the forest plots that I presented, a lot of the results were mired by either low or very low certainty with respect to the GRADE approach, which again limits our ability to draw definitive conclusions. So based on the totality of evidence and using the GRADE literature, what we can say for our conclusion is that in out-of-hospital cardiac arrest patients without ST elevation, early angiography may have no effect on mortality, survival with good neurological outcome, and ICU length of stay. However, it may decrease hospital length of stay, and the the words I've highlighted there reflect the certainty in the evidence as per some of the literature published by Dr. Guyot and Dr. Schoeneman as part of their grade series, that if you are at a low certainty, then the word you'd want to use is may, which is why we had went with this outcome. So that's all I have, but I'm happy to take any questions, and thank you for your time. I think I finished early, which is great.